Welcome everyone to the 2021 Corman IMPACT Honors program. I'm Sherry Carey, Director of Member Operations at the Schwartz Center for Compassionate Healthcare. We are thrilled that you've joined us to celebrate 3 inspiring programs represented by a group of outstanding healthcare professionals. The Corman IMPACT Honors celebrates Schwartz Center healthcare members who are making a transformational impact by creating programs or initiatives that promote compassionate, collaborative care within their organization or system. This recognition program would not be possible without its namesake, Steve Corman. Steve underwrites the IMPACT Honors program as a tribute to his late wife, Betsy, and to reflect his belief that leading by example is the most effective way to inspire others. Steve, all of us at the Schwartz Center are grateful of your continued generosity. We are incredibly lucky to have your support. Thank you is not enough. With that, I am pleased to introduce Dr. Beth Lown. Beth is the Chief Medical Officer at the Schwartz Center for Compassionate Healthcare and will serve as our moderator this afternoon.
Thank you, Sherry, and welcome to everybody. I am so excited to be moderating this wonderful, wonderful panel. I think you'll see why very shortly. Let me introduce the folks who are being honored this year. First, I'll introduce Dr. Jenny Siam, who is the Director of the Arts and Integrative Medicine, AIM for short, and the Youth Empowerment Series at Montefiore Medical Center. Jenny's a psychologist, a teaching artist, who's a national thought leader for best practices at the intersection of arts, education, and special education. She has taught thousands of students and trained their teachers to create and sustain arts programming in Central and South America, South Central, Los Angeles, and for the past 10 years at Montefiore in the Bronx, New York. You'll learn more about all of these wonderful people's programs shortly. Next is Karen Sutton. Karen Sutton is an LCSW, a social worker, behavioral health therapist at Grady Memorial Hospital in Atlanta, Georgia, who guided a grant-funded 36-month initiative called the Chronic Care Clinic to identify the social determinants of health and implement programs to increase health literacy, self-management skills, and community resource connection among frequent utilizers of emergency department services. Based on the program's effectiveness, Grady Memorial Hospital continued the program by absorbing it into its transitions of care clinic. And finally, I'll introduce Dr. Deborah Cook, an intensivist at St. Joe's Healthcare Hamilton in Hamilton, Ontario, Canada. She is a critical care researcher and 2021 recipient of a Lifetime Achievement Award from the Society of Critical Care Medicine, among other honors. Deborah spearheaded the creation, implementation, teaching, and evaluation of the 3 Wishes program, which began first as a research project to personalize compassionate acts for dying patients and their families in the hospital. The research project is now a clinical program ongoing in hospitals at and beyond Hamilton in Canada. So welcome to all of you. I'm so happy that you are all here. And we are going to begin this discussion. I'd like to begin by asking each one of you in turn to tell a brief story about your own personal pathway, who or what inspired you to create the programs that we're honoring today. I'll begin with Karen Sutton. Karen, why don't you go first?
Well, thank you and good afternoon, everybody. I'm glad to be here. And what I'll share is that my years of managed care, behavioral health, clinical oversight are really what drove my desire to return to direct practice. I definitely missed working with underserved populations, so I intentionally sought employment with Grady. And I'll just say, while I did not create the particular program that in our initiative, I was definitely there at the beginning for the initial formative work being done in terms of identifying those patients to outreach to, the ones who we identified as having the greatest unmet and unmanaged medical, social, and behavioral needs. So for me, it was my desire to sort of get my hands wet again. Sometimes when you're in managed care, you're a little removed from the front line. So I ran to Grady and it has been a rewarding experience.
Thank you, Karen. Let's hear a little bit from Deborah Cook, please. Dr. Cook.
Sure, thank you. Well, I practice critical care medicine at a university-affiliated hospital with McMaster. And in the ICU, as everyone knows, it's kind of a cold environment, a little bit sterile. Patients don't even look like people with the devices and the drips and all the technology that they are surrounded by. And dying in the ICU is actually quite common. So with a real desire to try to better humanize the process of dying in the intensive care unit, that stimulated a number of my close colleagues to just launch this program to try to personalize the dying experience a lot more by eliciting and then honoring terminal wishes. Those of the patient, if they're able, family members, and also acts of compassion from the clinicians.
Thank you. Thank you, Deborah. I hope it's okay if I address you each by your first names. Is that okay?
Definitely. Yes, it is.
Jenny, why don't you go next?
Sure. I'm going to name, it's so lovely to hear myself introduced, that I have taught thousands. That's because I've been around for a while. And so I've been teaching and have been an artist, a dancer, and a teacher and an actor for many years before I even became a psychologist. But one of the aspects of AIM and in thinking about what inspired me to bring it to Montefiore are individuals within and each one of those people. And so I want to name three. One, Elizabeth, a 45-year-old woman that I met way before I even went to graduate school while I was volunteering on a psychiatric inpatient unit. A 45-year-old woman with depression who had tried to kill herself by throwing herself in front of a train and only succeeded in injuring herself horribly and was paralyzed from the waist down. And as you can imagine, was extremely depressed, was on this inpatient unit. And to make a long story short, would observe me coming in and teaching dance, nothing I really knew how to do with a psychiatric inpatient, but I just was doing it. And 1 week, after weeks and weeks and weeks of knowing her, she came down to the group room, and the patients drew her in to the room and included her in her wheelchair, changed the movement so that it became arm movement, and just focused around her and created a sculpture. And at the end of, I said, I was shaking at how beautiful this was. And I said, thank you so much for coming. And she said, now I want to stop you and thank you, because I want to let you know that today, in my life, I never thought I'd feel beautiful again. And today I felt beautiful. So that's Elizabeth, and much shorter story is in Honduras, Brando, who taught me how to shimmy underneath barbed wire so that we could get into the school and do the arts programming when the matron would forget to unlock it. And finally, my teenagers in South Central LA, who were given the task of writing the show, creating the show, deciding on everything that would be part of a culminating event. And when they were asked, what do you want to call it? Said, why don't we go, Jose actually said, I wanted to name him, let's call it the best kept secret. I said, best kept secret? Why best kept? Oh, because everybody just thinks we're about gangs and drugs and violence, and best kept secret is that we're talented and we're skillful and we want to go to college and we're hardworking. And that has stayed with me and has become a part of the AIM programming in not keeping things a secret, in showing people and really making people visible and amplifying the voices of these very important individuals.
That's wonderful, Jenny. Thank you so very, very much. I'm going to ask each one of you to describe in a bit more detail what your program is all about, the key components, how it works, and so forth. So let's again begin with Deborah, and you can just tell us a little bit about what you've launched.
Sure. What we've tried to do as a community, and this began in our intensive care unit, but is happening on the hospital wards and in institutions elsewhere. The idea is to identify when a patient is dying. It's a process, as we know. There's a terminal event when they have passed, but often, especially in ICU, it's possible to plan the withdrawal or the withholding of life support. And as people come to terms with the end of life, that's often a vacuum, that period of time, and a tragedy, and there's so much angst. And while we never want it to be too late, what we try to do is think hard about the person in the bed as a person, not a patient. What matters to them? What would matter to them if they could speak for themselves? What would matter most? What would matter to their family? And who is this person beyond and before their critical illness? And then we try, the clinicians, to start the conversations and get to know more about people, and indirectly and directly elicit wishes, things that would be important to the patients or the families at the bedside when that was possible pre-pandemic, and what acts of compassion are called forth amongst the clinicians to try to make a horrible experience a little bit more comforting for all people bearing witness to the death and the patients themselves. So they're often simple, which has been one of our surprises, and it's been transformative for our community.
Mhm. You know, Deborah, just what Ken had said about making the unbearable bearable, exactly, you know, what you're trying to do with your program. Oh, goodness. Karen, can you describe your program a little bit better or more detail?
Sure, sure. Well, at Grady, our chronic care initiative was really designed to address the patients who had overutilization of the emergency department services. And so, you know, people come to the emergency department for different reasons. So it was really important for us to be able to try to investigate what's drawing this person, what's bringing this person. And so what I would say is a large part of our key components was having a very comprehensive team, a medical director, nurse practitioner. We had dedicated pharmacists, community health workers, medical social work, therapy, and patient navigators. Very detailed team, very specific goals. And what we wanted to do was first be able to address and target the unmanaged medical condition. We frequently dealt with unmanaged diabetes, unmanaged hypertension, congestive heart failure, COPD. And so we would address that medically, but then we were really focused on being able to look at the social determinants of health. What are the other things driving the patients to the ED? What are other ways that we could sort of help the patient? And then our initiative really too was focused on being able to increase health literacy with our patients. We wanted to also help those patients with community resource connection, because we often found that housing or lack of food insecurity and those things were playing a larger picture. And then also it was important to us that with our initiative, we'd be able to teach self-management skills. We had a lot of patients who, over the course of their life, it had just been a standard thing to run to the ED for every medical issue. And so the larger picture too was we wanted to be able to help teach the patients to successfully navigate a large health system. We understand how challenging that could be. And so that was our initiative. We had a lot of different avenues and a lot of different things we wanted to accomplish. But our goal was, we were hoping that if we did that, then we could graduate the patients to long-term primary care, and then they'd have a greater success rate of managing their own health and then being able to operate within the system. And so, you know, that's a large part of being able to find out what was drawing the patients to the ED so frequently.
Right, exactly. It's so interesting too. We know that, you know, that 80% of health outcomes are driven by all these social conditions.
Yes.
And, you know, what we do in healthcare really only accounts for 20%. So it's just so important. And the use of community health workers is I think, especially important, so completely underutilized.
Yes.
Thanks, Karen. Jenny, can you describe a little bit more about your program?
Sure. Arts and integrative medicine it's really, it comes out of the Department of Psychiatry, but it is available to the entire hospital community and the community that we serve, as for consultation of expanding upon best practices, whether that's medical practices or psychiatric practices. So it has as its base evidence-based practices of psychiatry in terms of how we address wellness, but expands. And I really resonate with Deborah talking about simple things, and with what Karen was talking about in terms of the social, what's going on in the environment, and needing to expand upon practices to address those things. For AIM, one of our greatest tools is the arts, also things like mindfulness practice, yoga, technology, and just really opening our arms wide to meet the patients where it's at. And I hadn't thought of this until Deborah mentioned these simple little things, but one of our, we have a program called the Youth Empowerment Series, which is under the umbrella of AIM, which really targets our young people in outpatient psychiatry. And one of our 19-year-old needed to be on, have a brain scan. And so he was in the hospital and very anxious and worried about confusion and about some memory loss that he had had. And, you know, we were able to come by and bring him a framed Van Gogh poster. He had just been to the Van Gogh exhibit and found that transformative and just something that was life-changing. And you know, we just sort of said, here, put this. It's not actually one of our big programs, but it's just like, he feels so anxious and so worried, and a simple intervention is let's hang this Van Gogh poster and look at that. So many other programs, but that are very, we have many group programs for art. We have a youth empowerment series art gallery, which is the main conduit in the hospital, so that our target is our patients, is patient families, the community, and the community of the hospital, so our healthcare workers. And so this is for everybody passing through that hallway. So whether they be a patient, to see the artwork of the patients who have been professionally mentored. Another big aspect of AIM and the Youth Empowerment Series is bringing in local community artists as mentors to partner with us, and just to serve as a further inspiration, but really always focused on the work of the patients, the work of these Bronx youth.
Yeah, and I remember you said in your documents that you had given cameras to a lot of the kids who were participating. What happened with all those photos? Did they go on the wall there?
Thanks. I get so excited. I'm so excited to meet everybody that I don't even remember aspects. Yeah, we were before the, thank you. At before, we had a wonderful opportunity, really exciting opportunity to work with a photographer, and it was sponsored. We had some very generous sponsors who donated cameras for to do a photo voice project. So we had teens involved with a professional photographer who was teaching them some techniques. And we were meant to have a big gala red carpet event, and have these and that they were handed the cameras, and we have some footage and video of them opening the cameras and experimenting with them. 2 weeks later, COVID happened and everything was shut down. And so all the plans to go to the botanical gardens and to go out throughout the Bronx and take pictures and, were just shut down. So we continued and started with photos, of canned goods and photos of lockdown and photos of locked schools and and ended up creating a video of montage of the photos throughout 9 months of pandemic living, and including protests, including all aspects of their life, which was then shown at Grand Rounds, and really celebrated their resilience and their strength, and inspired other people in the hospital. So they still have their cameras. I actually had one just say to me, when do I have to give you back my camera? And I said, no, it's yours. And he said, well, don't you want to do programs don't you want other kids to have it? Don't you want other kids to have the opportunity? Which I have to say is a giant aspect of this, and how much, not just the kids, everybody that we work with, so adults too, but this just happens to be a teen, a young adult, a young teen, and how much they want to give back, how much they want to share what they have experienced, whether it's through their artwork on the walls. So, but I want to say, very recent, this wasn't even part of the application. We just put up a new photo exhibit in the S Gallery, and we were taking down the drawings because we were just sort of able to get access. We were taking down the drawings of the prior exhibit, and we have people walking through saying, "No, don't take down this exhibit. We love this." We're like, "No, we're putting up new photos. We promise, we promise." So just a tribute to, you know, a testimony to how much, and, you know, Deborah mentioned surprises. I'm not surprised at all, because I've gotten to do this for many, many years. I'm not surprised at the impact on the participants. I'm not surprised at that it is impacting the environment of care, and we've done research on that. I am surprised how vocal people are at saying, "We want this. This is important. Don't take this down." That surprised me, how powerful it is that people are just speaking up and asking for it.
Yeah. Well, it takes you to another place, doesn't it? And it's moving, and it's inspiring to know that they want to sort of pay it forward. Thanks, Jenny. You know, I'd love to hear you share a story. Jenny, you've shared a bunch of stories about a memory, a patient, a family who participated in your program, and that really stays with you. And I'm going to ask you, Deb, to go first, if you would. Deborah.
Sure. There's so many, but one I was reflecting on today was a woman who'd had some chronic lung disease and was dying, and it was on New Year's Day, which is certain days, birthdays, anniversaries, and certain days of the calendar are really, really challenging, obviously, to lose a loved one. And this patient was conscious. And in our 3 Wishes program, we've been talking to her, of course, throughout her ICU stay, and asking about her family and some of the things that are important to her, what matters most. She's a great cook, and had a son who was also a chef. And one of the things that she was sort of gesticulating to him about what she'd really love to do is smell his broth. He made amazing broth, and they were chatting about it, and he sort of asked, "Is it okay if I bring this in?" Of course, he said yes, by all means, and she was able to smell it and feel great about that. And the smell and taste is another big feature of our program, and she had wanted her family to have their big New Year's Day dinner, which of course they couldn't have, but have a toast with her in the room, and we were able to facilitate that just in the tiny little medication cups. And they wanted us in turn to have a tiny little glass of wine in a medication cup to say thanks for opening this up. And in the touch is another big feature, touching special blankets that our community knitters have made instead of the crusty hospital blankets, and having her favorite sweater on that was soft. And speaking of the arts, as Jenny was, there was the son-in-law of this woman was an opera singer. And once we started to talk about personalizing this day as much as we possibly could, he was a person of very few words, the family said, but man, could he sing. And he asked, could he sing in her room? We said, sure. God, it was, he belted out Ave Maria in the room to her, and it was just, we were speechless. And it's just an example of some of the things that never would happen without cracking open an opportunity and discussing that's acts of compassion. And keepsakes, another thing that people grasp these fingerprint keychains that France and Neela and Feli and I and Anne, our main colleagues working on this from the team, and they say, can we have 7 of them? And they grasp them and walk out of the hospital. It's the last thing to touch their loved one. And that's what happened with this family as well. So it's just, it's a constellation of celebratory and simple events, largely costing nothing, but that was one particularly moving day. I will never forget.
Yeah. Oh my God, I'm crying. Just Deborah, can you say, I know that your program began sort of as a research project, and that's kind of transitioned to everybody can do it. And I think that's part of the power of it. Can you say a little bit more about that, you know?
Sure. I guess I'd always had end of life care as a special focus, a favorite focus of my teaching and practice. And share that with many people I know in our own hospital and well beyond. But the idea of beginning as a research project was to help give it some structure. You know, what is the overarching objective of fostering acts of compassion, encouraging them overtly, recognizing all the acts of compassion that are going on the world over. And by studying the phenomenon, not that that needs any legitimacy as a concept, but by studying it, it helps shine a light on it. And the research protocol just began to give it sort of overarching objectives and how will we do it and who will we do it. And we were very deliberate about trying to make it as interprofessional as possible. The lead research coordinator, France Clark, is a respiratory therapist, the lead nurse, the bedside nurse, Neela Hode, and our spiritual care clinician, palliative care, critical care, and everyone is involved. And so when we shared the protocol, something written down, and then people were able to, you know, follow along and engage. And I think it was grassroots. But the idea of a short document and making it a project of sorts helped to, you know, demonstrate what it was all about, why we're doing it. And then we went on to evaluate it for its affordability, sustainability, transferability, and value. So it's just not a bunch of nice little things you do, although that's great when that is done, but it became more of a clinical program in due course.
Well, you know, we're always asked to prove the return on investment for compassion, which I know drives me absolutely crazy. But you've actually been able to do it. If anyone wants to read a whole slew of papers about your initiative and now program, Deborah, they can find you on PubMed. There's a lot that's been written, and of course it's spread beyond your hospital. It's really quite amazing. And you involved the learners, students, residents, yes?
Yes, indeed. Yes. Obviously, it's a key domain of practice. Skill sets that aren't fostered as in a high profile sort of way, shall we say, for practitioners in training. And yes, they're very involved as well. And we encourage them to get to know, tell us something about patients other than their CT scan and other than their lab data. Tell us about them as human beings, however they are faring in critical care, but especially when they're dying and they engage in acts of compassion. And I remember one of our summer students who was in the ICU helping us went to go and get a piece of pizza that someone was able to have. And she was so into it and engaged. And she said, you know, I realize what I'm doing here, this is the most important piece of pizza I will ever buy. You know, and there's all kinds of lines like that and sentiments and statements that the learners have shared with us through the interviews, the qualitative data, and they've written their own paper about the meaning of it for them. So it does feel like an experiential education.
Yeah, it's so important too. You know, you just, we say we teach it, but until they're involved in learning who that person is in the bed on their own and meeting the family, it can't happen in a way that gets absorbed into the soul as it does when you're asking yourself or the student or the trainee or whatever. It's the best way to learn. Kieran, I don't know if you have any particular memories, people who participated that really sticks with you.
Most definitely. And I really was excited by this question because we have a patient that continues to check in with us periodically. We actually had a patient, she was spotlighted in an AJC article during one of our graduation ceremonies for a cohort group. And this particular patient presented to us with major depression, as well as hypertension and obesity. And of course, with our work with this particular patient, we also discovered that she was quite reclusive and that she had a very limited and physically distant social support system. And then along with that, she basically had chronic long-term unemployment. It had been nearly 10 years since she had worked, and she had been pretty successful in an administrative field. And then also she had suffered a very, shall I say, damaging divorce that she really didn't recover well from. And so slowly but surely over the years, she sort of just disappeared into herself and her home. And so when we began to work with her, the community health worker was incredibly instrumental in helping to pull this patient out, as well as the therapy sessions I was able to conduct with her. And what we found is that she had a lot of strengths. She had a lot of skills. She had a lot of abilities, but she had, doubted herself over the years.
Yeah.
And this particular patient was able to fight her reclusiveness and re-engage society by agreeing to teach a volunteer crocheting class. We just happened to find out that she loved crocheting. It was incredibly important to her. She loved it, had done it all her life. And so it took some while between myself and the community help sort of encourage her. She had her confidence in her ability to do it, but she questioned her ability to be able to teach others. And over the years, self-esteem had been damaged and she had, thought so poorly of herself, but we were able to encourage her. And through her commitment and hard work with teaching this crocheting class to other adults, she had great success. She was requested back multiple times. And doing that volunteer position turned into a part-time position with the library. And so we're talking someone who hadn't worked in nearly 12 years, agreeing to operate within her gift, and it turned into a part-time. And then I can tell you that we have been notified in the last 3 months that her part-time position is now full-time employment with benefits. So, compassion is all over this story for this particular patient. It took a long time, and I can definitely tell you that she did have one psychiatric crisis that resulted in an emergency room visit while we worked with her. But her recovery time was great. Her response to the team, her understanding of the value of taking the medication and taking it consistently, and then just agreeing to take those chances. And then we also had, some what I would call some practice sessions with her, where she could run through teaching the team, members of the team crocheting, where she was comfortable with us, and we were working to help build her confidence that she could teach to others. And so when I think about compassion healthcare, a lot of times I think about her because a lot of patience is required with patients. And so they need that time to rebuild. They need that level of understanding. And they just need the space to sort of talk about their fears. They need that room to be able to say out loud what they're afraid of and to be able to trust us to help them create a plan. So I'm so excited for this particular patient because she's highlighted in the AJC article. I'm hoping that one day they can do a follow-up on her because it would be a tremendous encouragement to others. But it is great to know that she is doing very well today. And it was definitely the team approach, but I have to definitely give lots of credit to the community health worker, accompanying her, helping her identify her strengths, being patient, making phone calls, assisting her with the application process, following up. All of those things make a tremendous difference. So yeah, it's very exciting, very rewarding, and I'm so happy for this patient. It has completely turned her life around.
I love that story, Karen. It's so much about walking alongside.
Yes.
Which is so important, knowing who that person is. And like you said, having the patience to walk alongside them. But you also, in your team, kind of mentored her into believing in herself. How many of us can really say, we've had a mentor who really believed in us and revealed to us something that we didn't even know about ourselves? It's an incredible gift, and it doesn't doesn't happen all that often, I don't think.
Exactly. And one of the things that was a great benefit for us is that we had the time to give by virtue of our initiative, and that we were designed to work with patients anywhere from 3 to 9 months. We didn't have to rush things with her. We can move at her pace. And we understand that in primary care, you don't always get that benefit. But because of our specific initiative to target this population, we had the time necessary to make the difference in her life. And incredibly rewarding. But you're right, patience is definitely for me a sign of true compassion in this field.
Yeah, absolutely, absolutely. Well, thank you for sharing that. Jenny, you've shared a bunch of stories. Did you want to share another story about somebody who was participating in your program?
Sure. Yeah, so many, as everybody has said, so many great stories and great individuals. And I think, again, I'm inspired by my colleagues here in terms of what to maybe emphasize a little bit. I'm thinking of one young man that we've known for about 4 years. And I guess I also want to bring into the discussion another part of AIM or the Youth Empowerment Series, which is our garden, the Yes Garden, and how that impacts on the environment of care, which is all of what we try to do with AIM, impacting on the caregivers throughout the hospital as well as the patients, and then that being a collaboration. So we have this young man who initially came to us when he was about 12, and some horrible things going on within the family because of immigration issues, and the father was taken out of the home and detained by ICE, and a lot of trauma impact on the family of many children, and he was depressed and angry and violent and punching things and trying to, and even his desire was I want to stop punching walls. That was really his treatment goal. I want to stop punching walls. And we actually did engage him in one of the art groups, and he did it, and he came, and he was, and he participated. And I'm thinking of Karen saying, we were patiently walking beside him. And again, the Youth Empowerment Program and AIM involves a lot of trainees. So our psychology interns, our psychology externs, and our fellows, and so lots of people, our psychiatry, working with this young man. And honestly, he's now 16, and this year participated again because of COVID. We weren't able to do the garden, the Yes Garden, which we started 2 years ago for the first time. But we said we're going to do it. We're going to do it on a small scale. It's outside. We're going to have just a few patients, not as many as we usually do, but patients for whom we think this is really important, and we can't garden online. And we invited this young man who, sort of always a little begrudgingly came, and, okay, I'll go. And came, and, like, oh, I don't know, what's that? My mom knows what that is. And in fact, his mom did, and would come and say, no, this is this, and this is, she would point things out, and her approbation was something very important to him. But then it was his group with 3 other teens, and he discovered a peaceful place in watering the garden, and would go and know where to, it was a learning curve because he had not done this from his Bronx apartment, but a learning curve in finding out where the hose was, turning it on, and then really taking ownership and charge, had his own plot of land, planted his sunflowers. But the most moving was just watering the garden. And I once just walked over very recently next to him and said, how do you feel? And he's just watering. And I said, how do you feel when you're watering the garden? How do you feel? Which is not how we usually talk, sort of often crisis management, and if he wouldn't feel safe, and he would take himself to the emergency room because he was worried that he might hurt somebody or hurt himself. But how do you feel when you were watering? And he said, I feel happy. And I had never heard him use that feeling term. I feel happy. And I just said, well, just keep watering. And, you know, this has become also a place for him. He is really known none other but gangs, you know, and tried to stay at home and actually was grateful for some time of COVID to keep him out of that setting. But in coming out, back out, didn't know how to even make friends or how to do things differently. And so watering and tending the garden and seeing these now towering sunflowers, which are his, and finding this peaceful spot, but also being able to interact with others and finding this new group that are tending to the garden. So that's a story.
Oh, God. These stories are just amazing. Thank you so much. It's so moving. It's those simple and not so simple acts of kindness and compassion that just change the world, you know? It's incredible. Okay, I'm going to get on to another question here. I'm always curious about, like, what's the secret sauce of your program? You know, what is it that makes it actually click and work? And why do you think that? So again, I think I'm going to start with you, Deborah.
Sure. It's such an interesting question because it's maybe depends on the perspective, whether it's from the perspective of people who sort of developed the idea or those who've been enamored with it and sort of running with it and taking it in its clinical program state forward. But I think from the beginning time, I would say it's the simplicity of the idea, the fact that it's a low-tech intervention in a high-tech setting where it did begin in the hospital, especially in the ICU. It starts with conversation and the connection that is often missing in healthcare, particularly when people are comatose or are, you know, alive with technology. And it is both patient and family centered. And I think all of those things sort of speak to the clinicians, and there's a need, there's an unmet need that I have always observed before something so explicit as this was encouraged. So the people obviously are key to making it happen. And I think the leadership of our interprofessional team fostering clinical champions at the bedside helped it have legs. And so the champions would learn about it and do it, and we collected data, and the data component was extremely important because we could tell the narratives and the stories, but we could also, through qualitative interviews, share what did families say weeks or months after their loved one had gone. What did clinicians experience caring for patients in that way? And we even interviewed managers, administrators, to ask what it meant from their perspective. And many were referring to the program being like a jewel in the crown of the institution, taking the mission and values off the page, right at the bedside. And so the research component, I think, really helped as well. The quantitative part, description of the wishes, and the narratives about what it meant. So I think, interestingly, the beginning as a research project grounded in patient-centeredness, that sort of helped with the longitudinal aspect of the research to transition phase to clinical program.
It's incredible, you know. Well, I know that you're a trialist, you're a clinical trialist, very experienced. But I love qualitative research. Can you share something that one of the family members might have said that made a difference, or you know, a patient before they passed away?
Well, one quote I remember from a gentleman whose aunt was the dying person. He, in the postmortem interviews very early on, was saying, you know, this is a simple but extraordinary program. And when something extraordinary like this is in the making, you can't stop. He said, you have to keep going. Otherwise, this will be another ordinary hospital. So when something extraordinary is in the making, you have to keep it going.
Wow, that should last a lifetime. Talk about motivation to continue on the hardest of days. Oh, thank you. Karen, what about you? What do you think is the secret sauce to the success of your program?
Yes, I would definitely say that it sounds very simplistic, but I'm going to say the people on the team.
Yeah.
Just to quickly highlight for those who may not be familiar with Grady. Grady is a safety net hospital. We're in the city of Atlanta. We're primarily serving the uninsured or the underinsured or the historically underserved populations. And I really believe that the secret sauce is having a heart for that population.
Mm-hmm.
And we have a team of people who have a heart for that population. And they were wholly invested in the well-being of each one of our clients. But I think also along with that, because we had so many different disciplines on the team, the secret sauce also that we were very fully equipped to address the needs and issues of the patients. We had someone who could do the medical. We had someone who could do the medication and explain what it's doing in their body and how it's impacting. Because a lot of times patients know that they're diabetic, but they don't understand how the medicine is working and the benefits. So having someone that could take the time to explain, who understands that we have varying degrees of education with the patients that we're working with. We have all kinds of limitations. And so for me, the secret sauce has always been the people on the team. And again, I'll take this moment to highlight our community health workers as being a tremendous secret sauce. Yeah. They are our eyes and ears on the ground. They were accompanying patients to other appointments, specialty appointments, to the Department of Labor, all kind of pursuits, things that the rest of the team could not do. And so the secret sauce for me is always going to be is going to be the people that are on the team, but the people on the team having a heart for the population that they're serving. You've got to have a heart for the population that you're serving. If you don't, you're already starting off missing the mark. And so for us, I would definitely say that the people on our team made a tremendous difference. Were the secret sauce. And there were many things that we probably would have never discovered had it not been for our community health workers and the level of engagement that they had with the patients in their community and in their home settings. That gave us great insight. And it's so shaped and directed a lot of the work that we were able to do in clinic. So yeah, people for me are always going to be the secret sauce. Always are going to be the secret sauce. You've got to have a heart for the people that you're serving.
Yeah, for sure. We don't use the word love in medicine very much, but yes. I hate to say it, but that's what powers us, right?
Yes, it does. It's always working behind the scenes.
It's the superpower of all caregivers.
Yes.
Thank you. Thanks, Karen.
Yes, of course.
Jenny, do you want to talk about that? What is it? What's the key?
Yes, I want to thank Karen and Deborah because I agree. And it's something extraordinary, and it's belief and faith, and it's belief and love for the people. I actually, in one of our art openings, said I said to my research assistant, I'm going to say love in this talk because I don't think I'm going to say love. This earlier when I was a teaching artist and training there, I said, it's easy to teach technique. I'm not sure I know how to teach love except for just standing in that truth, which is what Karen does and what Deborah and their teams do is standing, and what the Schwartz Center does is standing in the truth of love. And maybe we need to say it more and more and more. But so the secret sauce, I will say it because you did, Beth, is love. And really, though, very concretely, it is collaboration. I vetted Montefiore before I came, having done a lot of work in a lot of different places to say, here is a hospital. And then I met leaders like Dr. John Alpert, Dr. Sandra Pimentel, people who, that makes me emotional because from, leaders in that way, but really our collaborators are the people with whom we work. The stories that we're hearing from all of these programs, they are telling us what to do and guiding us in love and collaborating. So I believe 1,000% in sustainability, and wouldn't be doing this if it were, I've done the one-offs, and this needs to be able to continue. And what it requires, what the secret sauce is to require, is standing in the truth of love and the extraordinary and the people who matter, and maybe a little moxie or chutzpah in saying to the vice president, just give me a hallway, give me a really important hallway, and I'm going to now partner with fine art. And so it's I think collaboration I wanted to put front and center. Nothing is done without it's collaboration with the people that we're working with. It's collaboration with our trainees. It's collaboration with, got a shout out to the child outpatient division, every single one of them who celebrates the work. But it's standing in the truth of compassion and love, and just believing that, and just so maybe hard to teach, but what I get year after year after year after year, not only testimonials from the patients and from the kids, but also testimonials from trainees saying, I didn't know I could do that I should do that this just expands my world of how I can be, how I can look at somebody when they come into the room and say, you're amazing. You're so courageous and brave and extraordinary. How can we make that manifest? How can we? So, that is throughout, and I think it can be taught. I think I think that love can be taught, and maybe should be said more. But the secret sauce is collaboration and working with others.
This is really so profound, honestly. I mean, we've heard a lot, but I think I love your phrase, standing in the truth of love, walking alongside. But it sure helps to have support, collaborators, a team of people who also are walking alongside each other. And it helps to have data, and some kind of analysis to show impact. And I do want to ask you a little bit more about that. Deborah, I know you've done a lot of the research, but I'm just curious if you can say, and you've given us a little bit of the qualitative, what did you measure and what did you find?
Well, not everything that matters is measurable, which is why the qualitative is so important. So we've really benefited from qualitative experts in our community. Marilyn and Meredith, who've been incredible in that way, and obviously seeing it sort of from the insider outsider's perspective, and that's the value outcome. And we learned a lot through informal interviews with the bedside nurses who just carried this incredibly going forward. The numerical metrics, if you will, were fundamentals like describing the patient's age, like doing summary statistics on the number of patients who are cared for under the auspices of the Through Wishes program, and the number of wishes that were elicited and implemented. We also captured how many were elicited and then perhaps not able to be implemented, because we thought we should know if this is an infeasible sort of approach, and in fact we found it was almost always, these wishes are almost always implementable, and they were so simple. We classified them as a sort of more semi-quantitative, and found out over, things differed over the pandemic versus previously, what types of wishes. Not as many direct family-oriented ones, obviously, in the pandemic when the family's not present as previous, and the importance of the keepsakes, and as I mentioned. We also measured the time in the ICU until the death occurred, and how many opportunities we had for these kinds of conversations. We captured how many of the families reconnected with us afterwards, because obviously to understand the impact on them, you're not going to do an interview on the day that the loved one died. And there was a very high proportion of people were very interested in coming back to tell us about it, and through the interviews. We captured the cost actually as well, because early on we wondered if it would be an affordable intervention. And initially, some of our acts of compassion were sending fruit bowls to families' homes, or flowers to a funeral home, or something like that, which obviously that incurs some program costs. And we tracked over time, with the help of France Clark and many of our other trainees who spent time in our office, how the costs actually decreased over time, and the engagement of frontline clinicians and the initiators of the Through-ish program increased, and the research initiation decreased because of the uptake over time by the clinicians. Having counting the number of patients cared for and families cared for under the auspices was great. So the data were very important to the storytelling, and I think the dissemination within our own institution, the transferability outside, and the documentation of it being sustained.
Yeah. I think it's remarkable that all three of these programs have been sustained. And especially in the pandemic. I know they've been adapted and modified and so forth, but that is absolutely remarkable, and really sort of speaks to the power and the generalizability of them in some ways, or the transferability, I guess we should say. So it's fantastic. Karen, you did a lot of measuring too. I mean, it persuaded your leadership to absorb the program and continue it.
Definitely. And what I would add is that, our statistical outcomes reflected significant cost and utilization avoidance. And so what we were looking for, we wanted to compare pre and post quarter enrollment in our initiative. And then also looking at sustained cost avoidance 12 months post enrollment. So the two primary things we wanted to see is we wanted to see a decrease in emergency department utilization. And we wanted to see an increase in outpatient utilization. We all understand how it's much more expensive to be treated in the ED than it is to go to primary care. And we can definitely say our data reflects that all cohorts sustained a 30% reduction in emergency department utilization. And the average total cost reduction by program year was 62%, which is tremendous.
Yes.
And so the things we wanted to see, we definitely saw, but we also pay close attention to, and we counted our positive participant feedback. What the patients had to say to us on a survey regarding their experience with us. And we clearly had patients who indicated that they strongly agreed with the fact that we helped them to better understand and manage their health. We had patients that indicated that they achieved all of their designated goals. And then what was interesting to us too is that we had patients who indicated that they had greater confidence in their ability to reach out to their provider and greater confidence in their ability to advocate for themselves in their healthcare process. And so for us, that was really tremendous, because we work with a large population that sometimes struggled with realizing that they had a voice and that they needed to, even if they were questioning something or just needed clarity, often patients don't speak up. They have the experience of whatever the doctor says goes, or the doctor knows best, and they don't often explore and ask the questions that would help them better understand their treatment regimen. So when we have patients say they're more confident in reaching out to their provider, they're more confident asking questions, they feel encouraged that they understand. And then we have patients who basic things like, I talked about how we wanted to help them navigate the health system. Having patients tell us that they understand how to schedule an appointment, they know how to cancel appointment, they understand the necessity to keep specialty appointments because they're hard to come by. And then those patients who, eventually verbalized to us that they had greater confidence in understanding when it's appropriate to utilize the emergency department. And I know for some people, that may be a really simple concept, but we have had patients that we worked with that every time they were sick, they just went to the emergency department, never utilized a primary care physician or a nurse practitioner. And so to get them to a point that they understand certain things, certain medical conditions warrant an emergency room department, and others warrant calling your provider or maybe even using the nurse line to get some advice about what you should do. So we counted those things also as a success. So those positive participant feedback forms and just those patients who told us that they felt like they had never been listened to before, and they came to our clinic and now they felt like they had been heard and that they mattered, or that the family counseling made a difference and helped them in their interactions. A lot of times we were working with patients who really struggled with communication, so let's say assertive communication, and to find that their interactions with us and their work with with me as a therapist or the community health worker help them be able to better communicate their needs to their family. And in other environments, we saw growth in so many areas that, yes, we were very pleased with the decrease in emergency department utilization, but some of these other areas are incredibly important for the patients because those are going to be the things that are going to sustain their behavior change. And so we saw great success. We're very pleased. And of course, the entire team was happy to be engrafted into transitions of care so that we could continue this approach to working with patients. So yes, success was definitely on our side and we were pleased with the outcomes. It made a tremendous difference.
Well, your team and you made it happen.
Yes.
But it's so interesting because I think it takes skills training. These are skills. These are health literacy skills, right? And,
yes, they are.
You can't assume that everybody understands them. But the more confidence, the more competence someone feels in themselves and the more confidence they have, their self-efficacy predicts behavior, and it predicts behavior change.
Yes, it does. Yes. And that was really one of the things that was rewarding about our ability to work long-term with patients, because we understand that behavior change does not occur overnight. And so when people have had long established behavior patterns, they need time, as you say, to practice those new skills and put them into place. And they need repetition and they need support often to do those things. So it was definitely a rewarding experience to work on this initiative and with our population.
Wonderful. Thank you. I'm going to switch. We're at 5 o'clock, and I kind of want to just ask each of you in 3 words, how would you define compassion? Deborah, you want to unmute and just define compassion? 3 words. Unmute. Thank you.
Responding to suffering.
Thank you. That's wonderful. Jenny, what about you?
I'll say love, collaboration, interaction.
Okay, thanks. Hey, Karen?
I would definitely say understanding, patience, and love make a tremendous difference.
Yeah, it's terrific. Thank you. I do want to give time, if there are any questions, folks out there, can you please put them into, you can do the Q&A or the chat, doesn't really make any difference, but please do enter them if you have any questions. We have a lot of wonderful comments in the chat, a lot of accolades, and people are thanking everybody and just really enjoying and embracing all that you have said. We have one person, actually, From our team, fantastic explanations and such thoughtful, compassionate, and value-driven programs. Perfect fit for the Corman IMPACT Honors. We want to thank Steve Corman, who is listening in as we speak. Let me know if anyone has any other questions. Would any of you have any questions for each other? Or comments or anything else? You can feel free to speak. I'm not going to call on anybody.
Well, I'm just so grateful to be on this panel. Deborah, I may contact you about research. We sort of went the reverse and started with programming that I had done in a different world, from the education world, and are now. And I actually came to Montefiore to do research. That was the point, because we knew the programs work, but just will it work in a healthcare system? We have impact data on the difference, the change in stress levels for healthcare workers who encounter the Yes Gallery, and we have quantitative data on that, quantitative data on the impact of the garden as well, and a lot of qualitative data and quantitative data on the impact of the dance program on our kids. And but inspired to by both of you and all the research that you're doing. I really, it's very challenging, because I came to do the research and get swept up in the individual stories and wanting to do the programming, and then COVID. But we are moving forward with the kind of rigor that is needed just to sustain it, not to do the programs, but to sustain it and to make it grow, and to let other people have the kind of opportunities that Karen and Deborah are describing, that I feel are brought to the whole community by AIM. So just grateful to be here and to have compassion that the Schwartz Center just spotlighted. It is hard to measure, but not hard to understand.
So true, so true. Anybody else want to again, people who are on the screen right now should check out the chat, because people are just pouring love into you.
Oh, that's wonderful. And I would just like to add too that for me, I liked being in the company of the other awardees in terms of representing Grady, to hear that we are all working with a different focus, but very detailed and specific interests for particular populations. And I really loved hearing about AIM and the work done with young people, because I love the youth in that population. And then also so interesting, I just had a conversation with a colleague the other day about palliative care and how we come into contact with that issue in our clinic. And while we're not their long-term primary care person, we're wanting to figure out, are there things that we need to do, or are there dialogues that we need to be able to have or help our patients have when they're moving in that direction. So it was great to hear about Deborah's work and everything that was being done, and the fact that all of our work is being sustained. So, and then just in general, I'm also on the source committee for Grady here. And so I was just excited to even participate in the committee. So then to find out on the larger scale what's done nationally and the recognition, I just really am pleased to be a part of it. And I'm glad that compassion is a word that is being readily used and encouraged in healthcare, because it is so incredibly necessary, and it makes a tremendous difference. So just glad to be here today. This has definitely been good company.
Thank you.
I'd like to thank the Schwartz Center and Mr. Corman for existing, and thank you, Beth, for your grace, and everyone who works there, because having just a Center for Compassionate Healthcare is incredible. I mean, I have an embarrassing statement. I haven't even read an article about compassion until about 5 years ago. And I've come at this through end-of-life care, but obviously live my life, I hope, with passion and compassion for people who are alive, not just dying. And the approach started as research, as I've described. But just having institutions and entities and scholars and people telling their stories and having compassion as something that's visible is so important. It's so important. Just the very existence of this institution, the forum, and people. I feel very humbled.
Thank you, Deborah. You know, the Dalai Lama says that compassion is not a luxury, it's a necessity. Without it, humankind just won't survive. So I think, yeah, I think with that, I'm going to turn this back to Sherry Carey to close us out. I want to just thank everybody so very, very much. I've just been moved and inspired, and what a wonderful conversation. Thank you all.
Absolutely. Thank you, Beth, and thank you to each of our incredible honorees. We appreciate your dedication and compassion in healthcare and for taking the time to share your work with us. And thank you again, Steve, for supporting this important work. We also would like to thank our national business members. Without their support, the Compassion in Action Healthcare Conference would not be possible. And thank you to all of you, our audience. We hope that this program has left you inspired. Please consider joining us tomorrow at 3 p.m. Eastern for our closing keynote of the 2021 Compassion in Action Healthcare Conference. We'll be joined by Suleika Jawad, Emmy Award-winning journalist and celebrated TED speaker. Suleika is the author of the instant New York Times bestselling memoir, Between Two Kingdoms, which recounts her odyssey of healing and self-discovery after a diagnosis of leukemia at the age of 22 and given only a 35% chance of survival. We hope to see you there and wishing you all a restful evening ahead. Thank you.